Welcome to the Funnel Effect. We are diving into the global algorithm for the endovascular treatment of chronic femoropopliteal lesions, an interdisciplinary expert opinion statement published in JACICC. Cardiovascular Interventions, authored by Gregorios Korosoglu, Andrei Schmidt, Michael Lichtenberg, Nasser Moliar, Konstantinos Stavroulakis, Holger Reinecke, Gerd Kreuziger, Lorenzo Petrone, Ramon Alvarco, Peter Asokis, Dietmar Buckler, Christian Alexander Berendt, Eric A. Sashemsky, Thomas Eller, Erwin Blessing, Ralph Langhoff, and Christos Ramos. Wow, that's quite a list of contributors, 17 international experts. It really tells you this isn't just a small update, right? This feels like a major push for standardizing how we approach this. So our goal today is to give you, the learner, a clear path to understanding this new approach for peripheral artery disease, PAD. Specifically, we're looking at those tricky chronic total occlusions in the femoropopliteal arteries. That's the thigh and knee region. We're sort of moving past doing things case by case, ad hoc, toward a clear three-step method.
Exactly. And standardizing this is, well, it's incredibly important. The stakes are just so high. PAD means less blood flow, sure, but when you get to chronic limb-threatening ischemia, CLTI, we're talking about a serious risk of amputation, even death. For a long time, how these complex blockages were treated really varied. It depended a lot on, say, the doctor's own experience or maybe just what devices were available locally. This new algorithm, it's a global consensus. Trying to bring some predictability, some efficiency, it boils down to three key stages: evaluation, then preparation, and finally, the definitive treatment.
Okay, so three clear steps. But before we even get into step one of the endovascular algorithm, there's a big decision up front, isn't there? Is endovascular even the right path for this particular patient? Because the source material makes it clear, well, endo is common, maybe the most common first choice for fempop disease. It's not always the best choice.
That's absolutely spot on. The very first fork in the road is open surgery, like a bypass versus an endovascular intervention. And for those really high-risk patients, the ones with CLTI, we have some really important data from the BEST CLI trial that has to guide that initial conversation.
Right, BEST CLI, that was a landmark trial. Tell us, what exactly did it show about treating these patients who are really facing limb loss?
BEST CLI was crucial. It looked specifically at CLTI patients who were actually fit enough for surgery. They were randomized to get either the best surgical approach or the best endovascular therapy available at the time. And the key finding, well, it was a significant link between bypass surgery and lower rates of major adverse limb events, or MALE, but this was mainly in a specific group of patients.
Lower MALE. So does that mean fewer amputations with surgery or fewer times needing another procedure?
It was primarily driven by needing fewer repeat procedures, fewer reinterventions. The benefit really shone through for CLTI patients who had a good quality, great saphenous vein available for the bypass graft. That vein, taken from the patient's own leg, is kind of the gold standard for bypass conduits. It's known for being durable. So the trial basically suggested if you have a CLTI patient, they're fit for surgery and they have that good vein. Bypass seems to offer a more durable, longer-lasting fix compared to endo, fewer reinterventions down the line.
Okay, so that's a really critical point for the algorithm then. Endovascular might be the go-to procedure for many, but if the goal is saving the limb in a CLTI patient and they have a good surgical option with that vein, the team absolutely has to talk about surgery first. Multidisciplinary discussion is key.
Precisely. It has to be patient-centered, not just driven by the latest device. Endo isn't always superior, especially if you're dealing with, say, very long, complex blockages in a CLTI patient where you need robust, immediate flow restoration. You can't just jump to the quickest fix. But, once that big decision is made, once the team agrees that endovascular is the right way forward for this patient, then this three-step algorithm gives us the structure we need to really maximize our chances of success.
Right. So let's lay out those three steps again. This is the roadmap for how we're going to tackle femoropopliteal disease endovascularly now.
Yeah, it's designed as a logical flow. 1, evaluation of lesion morphology. This means using imaging both before and during the procedure, and we'll get into some advanced tools here to really understand the blockage. What exactly are we dealing with? You need to know the terrain, right? 2, selection of vessel preparation strategies. This is where we plan how to modify that blockage. Do we use a basic balloon? Do we need something more like atherectomy to remove plaque? Or maybe IVL, shockwave therapy? The goal is to get the best lumen gain with the least vessel injury. And 3, definitive lesion treatment strategies. This is the final step, securing the result. Usually using things like drug-coated balloons or maybe different kinds of stents if needed. It's all based on what we learned in steps 1 and 2.
Okay, makes sense. Let's dive into step 1 then.
Yeah.
Evaluation. You mentioned imaging. In the past, angiography, just injecting dye and taking an X-ray, that was kind of the main thing, was that? Why isn't that enough anymore? Why all this focus on high-tech imaging now?
Angiography is still important, don't get me wrong. But it's basically a shadow puppet show. It gives you a 2D silhouette. It dramatically underestimates how much calcium is really there. And calcium, well, that's probably the single biggest predictor of whether an endovascular procedure is going to fail. We need more detail. Is the calcium just spots here and there? Or does it wrap all the way around the artery? Is there old, organized clot, thrombus, still in there? Critically, did our guide wire actually get through the main channel, the true lumen, or did it slip underneath the plaque, subintimally? The answers to those questions dictate whether steps 2 and 3 are going to work or if we're setting ourselves up for failure.
Got it. So you start with non-invasive imaging like ultrasound. What does that initial look tell you?
Right. The first step is usually duplex ultrasound. And it's not just because it's non-invasive and avoids radiation. It gives us really valuable info. We can measure the lesion length, estimate the vessel diameter, and importantly, get a sense of the plaque morphology. Like you mentioned, duplex can often spot if there's a significant amount of organized thrombus. If you see that, the whole plan changes right there. You have to deal with the thrombus first, maybe with thrombectomy, before you start inflating balloons or using atherectomy. Otherwise, you risk sending clots downstream, which can be catastrophic.
Okay, and what about cross-sectional imaging, CT scans?
Computed tomography angiography, or CT, is fantastic for mapping out the calcium. It shows you exactly how much there is and, crucially, the eccentricity of it. Is the calcium piled up on one side eccentric, or is it wrapped all the way around like a ring concentric? Knowing that helps you choose the right tool later if you need to debulk. For instance, directional atherectomy might be better for eccentric plaque, while rotational might be needed for concentric. Magnetic resonance angiography, MRA, is another option. It avoids radiation, which is good, but it's generally not as helpful for looking at blockages inside old stents, in-stent restenosis, or ISR, and it's not great at showing us the details of the calcification compared to CT.
All right, this brings us to the imaging during the procedure. You mentioned intravascular ultrasound, IVUS. The source material really emphasizes this, calls it a game changer. What does IVUS actually let you see inside the artery?
Think of IVUS like a tiny ultrasound probe on the end of a catheter. You put it right inside the artery, and it gives you a full 360-degree real-time picture from the inside out. It lets you see the different layers of the vessel wall. You can clearly differentiate soft plaque, the fibrous cap covering it, and most importantly, exactly where the calcium is. Is it shallow near the surface, intimal, or is it deep in the wall, medial? That level of detail, you just can't get that from angiography alone. It's both diagnostic, what's there, and a measuring tool.
You mentioned measuring. How much better is IVUS at sizing the vessel compared to just looking at the angiogram? Does it really make that much difference?
Oh, a huge difference. Angiography relies on visual estimation and geometric assumptions, and it can be misleading. IVUS measures the actual dimensions of the vessel wall, often the external elastic lamina, giving you the true vessel size. So maybe the angiogram makes the vessel look like it's 6 millimeters. IVUS might show you the true boundary is actually 7.5 millimeters. Why does that matter? Well, if you undersize your balloon or stent in step 3, based on the angiogram, you get poor contact with the vessel wall, poor drug delivery if you're using a drug-coated balloon, and you're basically guaranteeing early failure. IVUS helps you nail the sizing.
And there was that randomized trial data mentioned. Routine IVUS actually changed the treatment plan in, what was it, 79% of cases. That's staggering. Now, for the learner listening, adding IVUS means more time, it's more complex, it costs more. Is the consensus really saying we should use it in almost all cases or just the really tricky ones?
Look, the data is pretty compelling. If you want the best possible outcome for the patient, the evidence supports routine IVUS use. That 79% modification rate wasn't just academic curiosity, it translated directly into better results. The same trial showed a really significant drop in restenosis rates at 1 year. Freedom from restenosis was 72.4% with the IVUS guidance, compared to only 55.4% without it. When you think about it, the small extra time and cost of using IVUS up front might very well prevent a major, much more costly reintervention or even an amputation down the road. It starts to look like a pretty good investment, maybe the cheapest insurance policy against failure you can buy.
That cost-benefit view makes a lot of sense. Okay, beyond sizing, what's the other really critical role IVUS plays, especially as we move into step 2, preparation? You mentioned safety.
Yes, absolutely. It's a crucial safety check. It confirms intraluminal guide wire passage. Did the wire go through the normal channel of the artery, or did it slip under the plaque? Many of the advanced tools we use for preparation, especially atherectomy devices that physically remove plaque, are designed to work safely only within that true lumen. If your wire has gone subintimal underneath the plaque, using those devices can be really dangerous. You risk causing massive tears or even perforating the artery. IVUS tells you definitively, yes, you're in the right space, it's safe to proceed, or no, pull back, reposition. Before you activate a potentially aggressive device, you need that confirmation. It's basically non-negotiable in this new algorithm, especially if you're considering atherectomy.
Okay, crystal clear. So step 1 is done. We have our detailed map thanks to imaging, maybe IVUS. Now we move to step 2, preparation. Choosing the right tool to modify that lesion. Let's start with the basics. Plain old balloon angioplasty, POBA, still the starting point.
Absolutely. POB is still the fundamental technique, especially if the imaging shows the calcification isn't too severe. It's often the first thing we do. But even POB isn't so plain anymore. The technique matters. The consensus statement emphasizes a best practice approach. Size the balloon 1-to-1 with the vessel, ideally based on those IVUS measurements we just talked about. Then inflate it gradually, not abruptly, and crucially, hold that inflation for a recommended 180 seconds, 3 minutes.
3 minutes, why so long? Standard inflations used to be much shorter.
It's about minimizing trauma. That prolonged, relatively low-pressure inflation allows the vessel wall time to stretch and adapt more gently. It reduces the sudden tearing and the elastic recoil, the vessel snapping back, that often happens with quick, high-pressure inflations. The goal is to avoid creating bad dissections, those tears in the vessel wall. Because if you get a major dissection, you're often forced into putting in a stent just to tack it down a bailout stent.
Right, and you mentioned the problem there, especially in complex calcified lesions. POB often doesn't work well enough, or it causes those dissections, forcing that bailout stent. And we know stenting in the fempop artery has high failure rates long-term, maybe up to 50% at 5 years.
Exactly. Which brings us to the more advanced preparation tools. These are specifically designed to tackle those difficult lesions and hopefully reduce the need for stenting later on. Let's talk about specialty balloons for scoring and cutting balloons.
How do those work differently?
Instead of just stretching, these balloons have small wires, scoring, or tiny blades, cutting, mounted on their surface. When you inflate them, they make very small, controlled incisions or scores in the plaque before the balloon fully expands. They're particularly useful for a fibrotic, tough plaque, or for moderately to severely calcified lesions, think calcium covering more than 180 degrees around the vessel. Or if a regular balloon just won't open the lesion fully, you see a persistent waste during inflation. They basically create predetermined fracture lines, allowing the vessel to open more easily and with less uncontrolled tearing.
And do they work? What kind of results are we seeing?
The data, often from registries rather than big randomized trials, looks promising for their specific indications. For instance, the chocolate balloon, which has this unique design with grooves and pillows, showed really high procedural success, over 85%, and needed bailout stenting in less than 2% of cases in one study. They fill an important gap between just using a plain balloon and having to resort to more aggressive plaque removal.
Okay, let's move to those more aggressive methods then. Atherectomy, physically removing the plaque. You touched on the different types: directional, rotational, orbital, laser. How do doctors choose which one based on the imaging from step 1?
It really comes back to that calcium map from the CT or IVUS. Directional atherectomy devices allow the operator to steer the cutting element, so they're generally preferred for eccentric lesions where the plaque and calcium are mostly on one side. You can target that specific area and shave it away. On the other hand, rotational or orbital atherectomy devices use a spinning burr or crown. They're often chosen for longer lesions with concentric calcium that hard ring all the way around. They basically grind or sand down the calcium to create a bigger channel. Laser is another option, using light energy to vaporize plaque.
The idea makes sense. Remove the blockage, let the vessel open up better, maybe help drug delivery from a DCB later. But you mentioned a trade-off. What did the definitive AR trial show us about atherectomy's risks and benefits?
Definitive Atherector did confirm that atherectomy helps mechanically. It significantly cut down the need for bailout stenting. Only 3.7% needed a stent after atherectomy, compared to a whopping 33.3% in the group that just got a drug-coated balloon. That's a big deal if you're trying to avoid leaving metal behind.
Yeah.
However, and this is the crucial part, there was a 6.3% rate of clinically significant distal embolization in the atherectomy group.
Embolization, meaning bits of plaque breaking off and going downstream, potentially blocking smaller vessels in the foot. 6.3% sounds like a pretty serious risk to take just to avoid a stent sometimes.
That's exactly the dilemma. You're trading the risk of a future blockage inside a stent, restenosis, for the immediate risk of showering debris downstream, embolization. And because of that risk, plus other studies like a Cochrane review, which found that while atherectomy reduced dissections and the need for bailout stents, it didn't actually improve long-term vessel patency or reduce the need for repeat procedures compared to just angioplasty. Well, the consensus is cautious. Bodies like SKI advise against using it routinely. It's considered an adjunctive tool, something you pull out for specific situations. Those really tough calcified lesions that just won't open with a balloon, and only if you've confirmed with IVUS that your guide wire is in the true lumen. It's not a first-line therapy.
Okay, that clarifies the role of atherectomy. Now let's talk about the newer approach for calcium. Intravascular lithotripsy, IVL, shockwave therapy. It sounds almost sci-fi, cracking calcium with sound waves. How does it do that without hurting the rest of the artery?
It's really quite clever engineering. IVL uses a special balloon catheter with tiny emitters inside. When you inflate the balloon to a low pressure, just enough to touch the vessel wall, maybe 4 atmospheres, you activate these emitters. They generate localized high-frequency sonic pressure waves. Now, these waves travel through the soft tissue, the plaque, the normal vessel wall, without really affecting them much. But when they hit the hard, brittle calcium deposits, they create microfractures. They crack the calcium.
So it's selective. It targets the hard stuff.
Precisely. You're disrupting the calcium structure without needing high-pressure balloon inflation that can damage the rest of the vessel wall. This makes the calcium more pliable, allowing the vessel to expand more easily and, importantly, with a much lower risk of causing those flow-limiting dissections we worry about.
That sounds very promising.
Yeah.
And the data. The Disrupt PIT trial was mentioned as key evidence. What did that show?
Disrupt PT3 was a big deal for managing calcified lesions. It compared IVL followed by a drug-coated balloon, DCB, versus just standard balloon angioplasty, POB, followed by a DCB. In patients with moderate to severe calcification, the IVL group had better procedural success, meaning they achieved a good result with less need for bailout stenting, 65.8%, SAS 50.4%. And critically, the IVL group had significantly better primary patency. The vessel stayed open at 1 year, 80.5% to 68.0%. And that benefit held up at 2 years as well, 70.3% as 51.3%. So IVL seems to deliver that sustained patency benefit in calcified lesions that atherectomy struggle to show consistently.
That improved patency is really the key outcome we're looking for. Okay, let's bring this section together. The Delphi consensus process got experts to agree on the preparation strategy.
Yeah.
Can you summarize the basic rules now? How do we decide which tool to use?
Yeah, the consensus provides a pretty clear pathway based on that lesion morphology we defined in step 1. It breaks down like this. 1, for mild lesions, not much calcium, not too fibrotic, stick with best practice POBO, using that long 180-second inflation. 2, for fibrotic lesions or moderate calcification, consider using specialty balloons, scoring or cutting, to get a more controlled dilation. 3, for heavily calcified lesions, especially those that won't dilate with a regular balloon, IVL is now often the preferred go-to tool to modify that calcium. Atherectomy remains an option, but again, only for selected cases and if you've confirmed intraluminal wire position. 4. And then there are the really extreme cases, the super calcified blockages you maybe can't even cross properly intraluminally. There's a special technique mentioned called the pave and crack technique.
Cave and crack, that sounds intense. What is that exactly?
It's definitely a last resort for the toughest occlusions. Basically, if you can't get through the normal channel, the operator might intentionally go subintimally and place a covered stent like Viabon across the blockage. This essentially creates, or paves, a new pathway for blood flow lined by the stent graft material. Then, after the covered stent is in place, they perform very high-pressure balloon angioplasty inside the stent. This is the crack part, using the force against the strong backing of the covered stent to fracture the underlying resistant calcium that couldn't be treated directly. It's complex, definitely an advanced technique.
Okay, understood. That covers step 2, preparation.
Yeah.
Now we've hopefully opened the vessel effectively. Step 3 is making sure it stays open, definitive treatment. For a while now, the mainstay here has been drug-coated balloons, DCBs, mostly using paclitaxel. But we have to touch on that big controversy from late 2018. There was a major safety scare, wasn't there?
Oh yes, that sent shockwaves through the entire field. December 2018, a meta-analysis gets published suggesting a possible link between paclitaxel-coated devices, both balloons and stents, and increased all-cause mortality at 2 and 5 years in PT patients. That led to immediate FDA warnings, regulatory scrutiny worldwide. It created huge uncertainty and concern. Doctors, patients, industry, everyone was asking, are these devices safe? It really challenged the standard of care at the time.
How did the field respond to that? How did we get from that crisis point back to where we are now?
It triggered an unprecedented level of investigation. Regulatory bodies like the FDA, researchers, and manufacturers collaborated to reanalyze the data, this time looking at individual patient-level data from the key trials, not just summary results. And as more data came in larger analyses, long-term follow-up from randomized trials, big real-world registries, the initial mortality signal started to weaken. Methodological issues with the original meta-analysis were identified. Consistently, the subsequent, more robust analyses failed to confirm a causal link between paclitaxel and increased mortality.
So the conclusion after all that scrutiny was,
The conclusion, supported by regulatory bodies like the FDA, who eventually revised their warnings, was that the benefits of paclitaxel DCBs in preventing restenosis and reintervention outweighed the potential risks suggested by that initial flawed analysis. So today, this global consensus statement reaffirms paclitaxel DCBs as an effective and safe primary treatment strategy for most femoropopliteal lesions, based on numerous trials showing they are clearly better than plain balloon angioplasty.
okay, confidence restored in paclitaxel DCBs. But that whole episode did push innovation, right? The statement mentions sirolimus-coated balloons, SCBs, as a new horizon. Is this likely to replace paclitaxel?
It's more about having options and alternatives. Sirolimus and its analogs have a long, successful track record in coronary drug-eluting stents. The paclitaxel concerns definitely spurred interest in developing sirolimus-based balloons for peripheral arteries. Devices like Magic Touch and Solution SLR are now available in many regions. They offer a different drug with a different mechanism of action to prevent restenosis. The big question is, are they as good as, or maybe even better than, the paclitaxel DCBs? We're waiting on the results from large, head-to-head randomized trials like the Sirona trial, which is directly comparing SCBs to DCBs. Those results, expected around 2025, will be really important in shaping the future standard of care. Will we see a shift, or will they coexist? We'll have to see.
Interesting. Okay, let's talk about when balloons aren't enough, or when step 2 results in a bad dissection or recoil. We need a permanent implant, a stent. What are the options there?
Right, sometimes you just need that mechanical scaffold. The simplest option is a bare metal stent, BMS, just plain metal mesh. They provide immediate support, hold the vessel open acutely. But as we've discussed, their big drawback is long-term patency. They tend to re-narrow fairly quickly due to tissue growth inside the stent, in-stent restenosis or ISR, especially in longer lesions or areas with a lot of calcium.
Then there are those specialized stents, the interwoven or biomimetic ones designed for the bendy SFA.
Exactly. The femoropopliteal artery twists and bends a lot with leg movement. Standard laser-cut stents can sometimes fracture under that stress. So stents like the Biomimics 3D use an interwoven nitinol wire design. The idea is that this helical structure makes them more flexible, more resistant to kinking and fracture, kind of mimicking the natural artery's movement. The registry data looks pretty good, suggesting they might perform well, but we're still waiting for strong randomized trial data comparing them directly against other stent types, especially drug-eluting stents. So they're an option, maybe for specific situations, but not yet universally proven superior.
Which brings us to the drug-eluting stents, DES. These combine the metal scaffold with the drug, like paclitaxel or everolimus, to fight that tissue regrowth. Systems like Alluvia or Zilver PTX, how do they stack up?
DES aim to give you the best of both worlds. The immediate mechanical support of a stent plus the long-term anti-restenotic effect of a drug. When you compare modern BS, like the Alluvia stent, which has a polymer coating for sustained drug release, against bare metal stents, the trials like Eminent clearly show DES are better. Improved patency at 1 year, confirming the drug effect helps.
Okay, DES beats BMS, but the bigger question is DES versus the primary strategy, DCB, maybe with a bailout stent if needed. Is it better to just put in a DES up front in some cases?
That's the really interesting debate, and the answer isn't always simple. Some trials compare DU, like Zilver PTX, directly against DCB therapy, where BMS could be used for bailout. At 12 months, the results looked pretty similar in terms of effectiveness and safety. However, when they followed patients out longer, to 36 months, there was a trend, though not statistically significant, suggesting the DES might have had better patency. Around 54% is 38% for the DCB strategy.
Why might DES have an edge over the long term?
The thinking is, in certain challenging situations, very long lesions, vessels with a lot of elastic recoil after ballooning, maybe areas of high movement, the permanent scaffold of the BES provides a continuous mechanical support that a balloon-only strategy, even drug-coated, might lack. It might prevent late lumen loss or collapse after the initial drug effect wears off. So the consensus kind of reflects this. DCB is the primary approach. But for those longer, more complex lesions or cases with significant recoil, or maybe in highly mobile segments like the popliteal artery, operators might lean towards using a DES up front, considering it provides better insurance against late failure. And finally, there's one more category. Covered self-expanding stents like Viabon, these are essentially stent grafts. They're different because they have a fabric covering over the metal frame. This completely aligns the artery, excluding the diseased wall from the blood flow. They've shown clear benefits over bare metal stents in randomized trials, especially for treating longer femoropopliteal lesions, significantly reducing restenosis. They're a very important tool, particularly for complex cases or bailout situations.
Okay, summing up step 3 then. The Delphi consensus showed 100% agreement that DCB is the standard primary treatment.
That's right. The algorithm clearly positions DCB as the first choice after adequate vessel preparation. Then DES, interwoven stents, or covered stents come into play either as a planned strategy for specific complex lesion types, long, calcified, high recoil, or as a bailout option if the initial DCB result isn't adequate due to dissection or recoil.
Makes sense. So we have this sophisticated 3-step process, but even if everything goes perfectly, restenosis can still happen. Let's talk about that specific challenge in stent restenosis, ISR. You said it happens in 30–40% of patients within a couple of years. That's common.
It is disappointingly common, yes. ISR means the blockage comes back inside a previously placed stent. It's usually scar tissue, neo-intimal hyperplasia growing through the stent struts. How we treat it depends on how bad it is. We often use the Tasaka classification. Type I is just a short focal narrowing, type 2 is more diffuse, longer narrowing, and type 3 is a complete blockage, a chronic total occlusion of the stent.
And how do we tackle ISR? Does the drug coating help here too?
Absolutely. Especially for the less severe forms, like Tasaka A or 2, randomized trials have clearly shown that using a drug-coated balloon to treat ISR is much better than just using a plain balloon. DCBs significantly reduce the risk of the ISR coming back again, cutting the need for repeat procedures by around 45%. So guidelines strongly recommend DCBs as the first-line treatment for most ISR.
But what about those really bad cases, the type 3 occlusions where the stent is completely blocked?
For those more severe, diffuse, or occlusive ISR lesions, the approach often needs to be more aggressive. Some operators might use debulking first, maybe atherectomy, to physically remove some of that overgrown tissue from inside the stent before using a DCB. However, another strategy, which is gaining favor based on trial evidence, is to use a covered stent. Placing a covered stent inside the failed bare metal stent essentially relines it and seals off the restenotic tissue. The reline trial showed that covered stents were superior to plain balloon angioplasty for treating femoropopliteal ISR, particularly the more severe types.
Okay, so the algorithm gives us technical guidance based on the lesion, but you started by emphasizing the patient-centered approach. How does the patient's actual clinical situation? Are they just having claudication pain when walking? Or are they facing imminent limb loss with CLTI influence these technical choices? Does it override the algorithm sometimes?
It absolutely acts as a major filter. The patient's condition fundamentally shapes the treatment goals and risk tolerance. For CLTI patients, the #1 priority is saving the limb. Now, flow needs to be restored quickly and reliably to allow wounds to heal and prevent amputation. So operators treating CLTI are often thinking about durability above all else. They might have a lower threshold for using a permanent implant like a DES or a covered stent, even if a DCB might technically work. They want the most definitive, robust result possible right away, minimizing the chance of early failure that could cost the limb.
They can't really afford to wait 6 months and see if a DCB result holds up if a wound needs to heal now.
Exactly. It's about immediate, reliable flow. Now contrast that with claudication patients. These patients have pain with walking, but their limb isn't immediately threatened. They are typically more active, walking longer distances. For them, the operator might be more focused on preserving future options and minimizing the long-term risks associated with permanent implants, especially in flexible areas like the SFA or popliteal artery, where stents can fracture or develop severe ISR over time due to movement. So for claudicants, operators might be more inclined to stick with the DCB-first strategy, accepting a potentially slightly higher chance of needing a reintervention later in exchange for avoiding a permanent implant now. It's a different risk-benefit calculation based entirely on the patient's clinical state and lifestyle.
That's a really important distinction in applying the algorithm. Okay, this expert statement provides a fantastic framework, but the authors were upfront about limitations too, weren't they? And what are the big unanswered questions for future research?
Yes, they acknowledged limitations. Much of the supporting evidence still relies on observational studies or registries, not just high-level randomized trials for every single decision point. Patient groups and older trials were often mixed, making it hard to draw conclusions for specific subsets like complex CLTI. And historically, many trials focused more on the less severe claudication patients, the biggest unmet need, more head-to-head comparative data.
Comparing what specifically? What trials do we really need now?
We need high-quality randomized trials directly comparing the most advanced endovascular strategies against each other. So that means taking a full lesion modification plus drug approach like IVL or maybe optimized atherectomy, followed by a DCB with bailout stenting as needed, and comparing that directly against upfront treatment with the latest drug-eluting stents. Which strategy gives the best long-term results for complex lesions, and perhaps the most critical need, especially for those really long, challenging femoropopliteal blockages, particularly in CLTI patients? We need modern, well-conducted trials comparing the best endovascular approach we have today directly against the best contemporary bypass surgery, fully considering the insights we gain from best CLI about vein grafts and patient selection.
Right. So it feels like we have a much clearer, more sophisticated playbook for endovascular treatment today, but the ultimate long-term winner for the most complex disease is still being investigated. Okay, let's try to wrap this up. For you, the learner, listening to this deep dive, what are the key takeaways from this new global algorithm? Well, first, it's clear the standardization is here. We're moving away from just doing what we feel like towards a structured approach. Second, imaging is absolutely key, especially IVUS. It's not just optional anymore. It fundamentally changes the plan in most cases by giving precise measurements and confirming safety. Third, vessel preparation is now tailored. It's not just POBI. We have advanced tools like IVL for calcium and specific uses for atherectomy. And finally, for the definitive treatment, DCBs are the primary workhorse. But stents, particularly DES and covered stents, have crucial roles for complex lesions, for critical limb ischemia, and for tackling that difficult problem of in-stent restenosis.
That's a great summary. And maybe a final thought to mull over. Even with this incredibly detailed, evidence-based algorithm and all this amazing technology, the success of any individual procedure still often hinges on the specific skill and experience of the person performing it, and practically on whether these advanced tools are actually available at their hospital. It just emphasizes that, despite our best efforts to standardize, medicine is still practiced by individuals, and in the real world, a true one-size-fits-all solution probably isn't available for every single patient and every single blockage. There's still an art alongside the science. Thank you for watching The Funnel Effect.